Welcome to this presentation. This will be a lecture on child psychiatry. I'll be attempting to cover the following topics: ADHD, conduct disorder, autism spectrum disorders, intellectual disability, tic disorders, enuresis, school refusal, elective mutism, sleep disorders, and stammering. As usual, we will conclude with a set of 5 self-assessment multiple choice questions based on the material covered. Some information about myself. I am a consultant psychiatrist based in Chennai, which is a city in southern India. I have worked for many years in the United Kingdom. We will begin with ADHD. ADHD stands for Attention Deficit Hyperactivity Disorder. It is a diagnosis in DSM-5. In ICD-10, the equivalent diagnosis is hyperkinetic disorder. The main clinical features of ADHD are inattention, hyperactivity, and impulsivity. These symptoms should be present both at home and at school. Symptoms should be persistent for at least 6 months. Symptoms should affect social behavior and academic performance. The age of onset should be less than 7 years according to ICD-10 or less than 12 years according to DSM-5. The inattention in ADHD manifests itself by an inability to sustain attention in tasks. The child is easily distracted by external stimuli, appears not to listen to what is being said, is unable to follow through on instructions, is forgetful in daily activities, has difficulty organizing activities, often loses or misplaces objects such as books, pencils, or toys, makes careless mistakes, and avoids tasks involving sustained mental effort. There is excessive motor activity that is disproportionate to what the situation wants. The child fidgets with hands or feet, squirms in seat, often leaves the seat in class, has a tendency to run about inappropriately. Older children may report feeling restless. The child is excessively noisy and always appears to be on the go. There is a general tendency to act without thinking, talks excessively, blurts out answers before questions are completed, does not wait for one's turn, interrupts the conversations of others, intrudes into the activities of others, we will now look at the epidemiology of ADHD. The prevalence in children of DSM-5 ADHD is about 4%. The prevalence in children of ICD-10 hyperkinetic disorder is about 2%. ADHD is 3 times more common in boys than in girls. Inattention is likely to be the prominent feature in girls with ADHD, while hyperactivity and impulsivity tend to dominate the picture in boys with ADHD. So boys are more likely to come to the attention of clinical services. ADHD is more common in lower socio-economic classes and in children brought up in institutions. We will now look at the etiology of ADHD. In DSM-5, ADHD is included under the category neurodevelopmental disorders. The exact cause of ADHD is not known, but contributory factors may include genetics, as there is an increased risk if family history of ADHD is there. It could be a manifestation of executive dysfunction or frontostriatal dysfunction, monoamine dysfunction. There might be a delay in cortical maturation. As a group, children with ADHD have a slightly lower total brain volume on neuroimaging when compared with controls, and also show an increase in slow waves on EEG. There is an increased risk of ADHD in very low birth weight children, so children who weighed less than 1.5 kilograms at birth. Maternal smoking during pregnancy, food additives may be a factor, lead intoxication, infections such as encephalitis. It is important to do a thorough assessment to establish the diagnosis. The Conners rating scales are commonly used for grading severity. Educate the child, parents and carers and teachers about the disorder, with special emphasis that the child is not to be blamed for his or her behavior. If available, parents' education or training programs in a group setting should be offered. Simple healthy living advice such as a balanced diet and regular exercise can help. If certain ingredients of food or drinks such as additives or coloring agents appear to worsen symptoms, confirm this with a food diary and consider excluding them from the diet. If available, seek the advice of a dietitian. Mild to moderate ADHD may respond to simple behavior therapy, especially if comorbid conduct disorder symptoms are also present. Social skills training can be beneficial. For severe ADHD or for moderate ADHD not responding to other interventions, medication should be considered. The medication for ADHD include stimulant drugs such as methylphenidate and amphetamines, and non-stimulant drugs such as atomoxetine. These drugs are usually administered orally. Methylphenidate is also available as a patch. The exact mechanism for efficacy of medication in ADHD is not known. Methylphenidate is a CNS stimulant. It inhibits dopamine reuptake by blocking the dopamine transporter. It increases dopamine and noradrenaline in the frontal cortex and in subcortical regions that are involved in reward and motivation. Atomoxetine is not a CNS stimulant. It blocks noradrenaline transporter and increases noradrenaline. Side effects of methylphenidate include headache, reduced appetite, so check the child's weight and height regularly, insomnia, raised blood pressure and pulse rate, so check the BP and pulse rate regularly. At high doses, methylphenidate may rarely cause psychosis or tics or lowering of seizure threshold. Methylphenidate patch may cause permanent loss of skin pigmentation, so-called chemical leukoderma. The side effects of atomoxetine appear to be similar to methylphenidate but less severe. Rarely it might induce suicidal ideas. For ADHD with comorbid Tourette syndrome, which is a tic disorder, atomoxetine is the drug of choice. Both atomoxetine and methylphenidate can rarely cause priapism in males. As far as the long-term course of ADHD is concerned, in general, symptoms tend to decrease in severity as the child gets older. Compared to non-ADHD controls, ADHD is associated with lower future levels of educational achievement and occupational status. Untreated ADHD is associated with poorer outcomes compared to ADHD that is treated. Among those who are treated, a combination approach combining pharmacological with psychosocial approaches appears to result in best outcomes. In about a quarter, some ADHD symptoms may persist into adulthood. If ADHD is comorbid with conduct disorder, there is an increased risk of future substance misuse and antisocial personality disorder. This is more likely to be a consequence of conduct disorder than of ADHD. We will now move on to conduct disorder. In conduct disorder, there is a repetitive, persistent pattern of age-inappropriate behavior that violates the basic rights of others. According to DSM-5, the onset has to be before the age of 13 years. ICD-10 specifies two subtypes: a childhood onset type before 10 years and an adolescent onset type after 10 years. ICD-10 specifies a duration of at least 6 months, while DSM-5 specifies a period of at least 1 year. Juvenile delinquency is a legal term referring to criminal acts done by a young person who has not yet reached the age of being liable to prosecution. A child with conduct disorder defies rules but blames others, repeatedly lies, engages in criminal activities, shows physical cruelty to animals, aggression towards people, intimidates and bullies others, gets into frequent physical fights, deliberately destroys property or sets fire to property of others, may use a dangerous weapon such as a knife or even a gun. There is truancy, staying out after dark, running away from home, deliberately annoying others, forcing another into sexual activity, deceiving or manipulating others, lack of remorse or guilt, and callous unconcern for the feelings of others, that is a lack of empathy. In ICD-10, oppositional defiant disorder is a type of conduct disorder. In DSM-5, ODD is diagnosed as a separate disorder. The main features of ODD are being headstrong, so the child deliberately disobeys the requests or commands of elders and argues with adults, has an angry, hostile, resentful, vindictive, or spiteful attitude, is easily annoyed, and displays temper outbursts. In contrast to conduct disorder, serious violations of societal rules are not common in ODD. Younger children displaying ODD are at a much higher risk of showing a full-blown conduct disorder when they are a bit older. The other types of conduct disorder in ICD-10 are conduct disorder confined to the family context, socialized conduct disorder where the child has normal relationships with peers, and unsocialized conduct disorder where the child is not a popular member among his or her peer group. Risk factors for conduct disorder include low socioeconomic status, low achievement in school, large family size, living in an inner city area, child abuse or neglect, parental, usually paternal criminal history, parental conflict, separation or divorce, and parental substance misuse problems. The prevalence of conduct disorder is about 5%. It is about 3 times more common in boys than in girls. The severity of symptoms are also higher in boys. The earlier the onset, the greater the risk of persistence into adulthood as antisocial personality disorder. In oppositional defiant disorder, the male to female prevalence difference is not as pronounced as in conduct disorder. In fact, after puberty, both males and females seem to have similar prevalence rates of ODD. Do a comprehensive assessment with information from the child, parents, carers, teachers, police, etc. to establish the presence, nature, and severity of any conduct disorder. The Strengths and Difficulties Questionnaire is a commonly used assessment tool. The Child Behavior Checklist is another useful instrument. Assess for the presence of conditions that may be comorbid with conduct disorder, such as ADHD, autism, intellectual disability, substance misuse, etc. Establish the nature of the child's relationships with his or her parents and with peers and teachers. In severe cases with numerous antisocial behaviors, do a risk assessment. Skills training for the child may be beneficial. Emotional skills training, helping to improve awareness of the emotional state of oneself and of others. Learning self-control of negative emotions without acting out behaviorally. Improving one's self-esteem. Social skills training to improve relationship with peers. And problem-solving skills. Parental skills training can also be beneficial, ideally involving both parents. Behavior therapy and family therapy can also be beneficial. Behavior therapy to encourage and reinforce positive behaviors and to gradually reduce and eliminate negative behaviors. And family therapy if there is significant dysfunction within the family that is being expressed through the child's behavior. Rarely, for severe conduct disorder with unpredictable aggressive behavior, a short term of low dose antipsychotic, for example an atypical antipsychotic like risperidone, may be indicated. We now move on to autism spectrum disorders. ASD is the term used in DSM-5. In ICD-10, this category is called pervasive developmental disorders. ASD or PDD include the following disorders: autism and Asperger's syndrome or Asperger's disorder. Autism represents the more severe end of the ASD spectrum. In Asperger's, the language or intellectual impairment are not as prominent. Autism is also called Kanner's syndrome or infantile autism, while Asperger's syndrome is also called high-functioning autism. The main features of autism are abnormalities of reciprocal social interaction, abnormalities of communication, and repetitive and restrictive behaviors. A majority of patients with autism have an IQ below 70. Children with autism dislike being cuddled, kissed, or picked up. They seem to not have interest playing with other children. There is poor eye-to-eye contact. They prefer to be alone. There is lack of empathy, reduced facial expressions, impaired ability to establish friendships or warm relationships with others. There are cultural differences with respect to social interaction, so assessment of abnormalities should take into account cultural factors. Both verbal and non-verbal communication are affected in autism. There is delay or sometimes even an absence of development of speech and language. Conversation with others tends to be a monologue rather than a dialogue. There is a tendency to talk repetitively about what one has already spoken about. There may be echolalia, repetition of what the other person has just said. There might be errors in pronouncing syllables or words. There might be improper choice of words. And in some cases, there might be incoherence in speech. There might be stereotypical behaviors like repeated body rocking, hand clapping, head rolling, or whirling round and round. There might be insistence on sameness. So the child might prefer to wear the same clothes, play with the same toys, eat the same food, take the same route, etc. There might be fascination with spinning toys or washing machines. And the child might appear to be lacking in creative imagination. Other features of autism might include overactivity, unpredictable behavior, in some cases self-injurious behavior. In about 25%, there is comorbid epilepsy. Some children with autism have exceptional ability in certain intellectual areas, for example, memory or mathematics. About 1% of the population have an autism spectrum disorder. The male to female ratio is about 4 to 1. Prevalence has been increasing and might reflect a combination of better awareness, earlier recognition, a relaxation of diagnostic threshold, or maybe a true increase in prevalence. Risk factors for ASD include genetic factors. More than 60 potential candidate genes have been identified, some of which are also associated with increased risk of other disorders like schizophrenia, intellectual disability, epilepsy, etc. Some cases are associated with duplication of a section of chromosome 7. Interestingly, patients with Williams syndrome, in which the same section of chromosome 7 is deleted, display excessive sociability. Low birth weight, first trimester exposure to drugs such as sodium valproate may be a risk factor for ASD. Advanced parental, especially paternal age. There is an extreme male brain theory that has been postulated. According to this theory, normally males are better at systemizing than at empathizing, and the converse is true for females. In autism, there is an exaggerated male pattern with even more extreme systemizing and even less empathizing. Potential role of sex hormones, especially testosterone, has been postulated. Psychologically, theory of mind deficit is considered to be a key feature of autism. Theory of mind refers to the ability to understand the mental states of other individuals. This usually develops between the ages of 3 and 4 years. By 8 years of age, this ability further develops so that a child can normally assess even complex mental states of others, for example, being able to detect a bluff. Children with autism appear to lack theory of mind and report only what they themselves know. So a child or an adult with ASD lacking theory of mind is vulnerable to exploitation. Theory of mind deficits are also seen in schizophrenia. Theory of mind is related to empathy, but they are not identical concepts. Subjects with ASD lack both empathy and theory of mind, whereas psychopaths who habitually cheat others lack empathy but have theory of mind. Theory of mind is universal and transcends cultures and languages. The so-called mirror neuron system is supposed to be the biological basis of theory of mind. Mirror neurons are widely dispersed in the brain and are activated when an individual either performs an action or observes the same action being performed by another individual. I have listed a few experiments that are used in studies to assess theory of mind. Please refer to my lecture 10 Landmark Studies in Psychology for more information on theory of mind. Do a thorough assessment to establish the diagnosis and severity of ASD. I have listed a few rating scales that are used in this field. Assess what additional support the family needs in managing the child and offer such support where available. Educate the child, parents, and teachers about the disorder. Social skills training, communication skills training, life skills training may be beneficial. Behavior therapy to reduce maladaptive and to promote more adaptive behaviors. For extremely challenging behaviors, a low-dose short-term atypical antipsychotic can be considered. Symptoms can worsen when there are transitions, for example, change of school or change of residence or carer, so extra support would be needed at such times. Respite care in a suitable environment for the child can help the parents take their own well-deserved breaks from the constant routine of caring for an autistic child. We now move on to intellectual disability. This is a diagnosis characterized by an IQ of less than 70 that results in significantly impaired functioning. The general population mean IQ is 100 and the standard deviation is 15. So an IQ less than 70 represents a score that is at least 2 standard deviations below the population mean. Intellectual disability is the term used in DSM-5. The equivalent diagnosis in ICD-10 is mental retardation. Other related terms include learning disability and intellectual developmental disorder. ICD-10 subdivides mental retardation into 4 categories based on IQ: mild, moderate, severe, and profound. DSM-5 also subdivides intellectual disability into the same four categories, but based on severity of impairment in what is called adaptive functioning. Some experts divide these patients into just two groups, mild and marked. Intellectual disability can also be subdivided based on the extent of external support that a patient needs. Social adversity may play an etiological role, especially in mild intellectual disability. The more severe the intellectual disability, the more likely that the cause is purely organic. Genetic syndromes that can cause intellectual disability include Down syndrome, Fragile X syndrome, Prader-Willi syndrome, inborn errors of metabolism such as phenylketonuria and Tay-Sachs disease, Lesch-Nyhan syndrome, infectious causes such as congenital rubella syndrome, encephalitis, meningitis, and toxic causes such as fetal alcohol syndrome or lead intoxication. Traumatic factors such as obstetric complications or severe physical abuse may also play a role. An IQ of less than 70 is seen in about 1% of the population. Overall, intellectual disability is more common in males. This male preponderance increases as the severity increases. Among those who have intellectual disability, more than 80% have the mild subtype, while about 10% have the moderate subtype, about 5% the severe subtype, and about 1% have the profound subtype. Mild intellectual disability is much more common in lower socioeconomic groups. More severe intellectual disability has a similar prevalence across socioeconomic classes. Assessment that is aimed at identifying an underlying medical cause for the intellectual disability is usually the purview of the pediatrician. A diagnosis of an underlying cause can be made, usually, especially in severe and profound intellectual disabilities, based on a combination of a thorough history, examination, and specific investigations. The IQ can be measured using the Wechsler Intelligence Scale for children, and social functioning can be assessed using the Vineland Adaptive Behavior Scale. Depending on the severity of the intellectual disability, provide additional support in school, special needs schooling may be needed, remediation education, vocational skills training, social skills training, behavior therapy, supportive counseling for parents and carers, identify and treat any comorbid mental disorders. For aggression and agitation, can consider atypical antipsychotics, lithium, other mood stabilizers, benzodiazepines, etc. In general, patients with intellectual disability are at higher risk of side effects, so use psychotropics only if necessary and use lower doses than normal. It is important to adequately manage any comorbid epilepsy, which is much more common in this group of subjects. We will now look at tic disorders. A tic is a sudden, involuntary, non-rhythmic, jerking, motor or vocal activity. Tics can be divided into motor tics and vocal tics. Both motor and vocal tics can be further divided into simple and complex tics. Examples of motor tics include blinking eyes, shrugging shoulders, jerking the head, and making obscene gestures called copropraxia. Examples of vocal tics include throat clearing, grunting, coughing, and saying swear or obscene words, which is called coprolalia. Some patients display echolalia and echopraxia. Echolalia is repeating what the other person is saying, and echopraxia is mimicking what the other person is doing. Some patients experience only motor tics or only vocal tics. Many patients experience only transient tics which disappear within a few months. The classic tic disorder is Tourette syndrome, named after Gilles de la Tourette, the French physician who first described this disorder. Tourette syndrome is characterized by chronic combined motor and vocal tics. Tics usually occur in episodes or bouts. Many patients report a preceding urge or sensation before a bout of tics occurs. As a result, some patients, especially older children and adults, are able to suppress or delay an episode of tics. Many patients report a sense of relief after a spell of tics. Tics may occur during sleep also. All types of tic disorders are more common in boys than in girls. About 5% of school-age children experience transient tic disorder. About 1% of school-age children experience a chronic motor tic disorder or a chronic vocal tic disorder. The prevalence of Tourette syndrome is about 4 per 10,000 and is 3 times more common in boys. Tics are unlikely to develop for the first time after the age of 15 years. Simple tics are more common than complex tics. In Tourette syndrome, motor tics usually precede vocal tics. Coprolalia or obscene speech, which has been popularized in TV, movie, and media portrayal of Tourette syndrome, is seen in only a minority of patients. Do a thorough assessment establishing the age of onset of tics, the course, family history. Assess for presence of comorbid disorders like ADHD, autism spectrum disorders, OCD, depression, etc. The severity of the tics can be assessed using the ALE Global Tic Severity Scale. If features are atypical or if you cannot rule out a neurological disorder like myoclonus or dystonia, consider referral to a neurologist or investigations such as CT, MRI, or EEG. If mild or transient, reassure and monitor the cause of the disorder. Behavior therapy include habit reversal training, exposure and response prevention. Pharmacotherapy include antipsychotics like risperidone, haloperidol, aripiprazole, pimozide or sulpiride, and other drugs such as clonidine, tetrabenazine, guanfacine. In severe treatment-resistant cases, botulinum toxin injection or deep brain stimulation may be potential options. We will look at enuresis. Normally, children gain control over their continence by the age of 4 years. If urinary incontinence persists beyond this age, a diagnosis of enuresis can be made. Usually, enuresis occurs only at night and is called nocturnal enuresis. Less commonly, both nocturnal and diurnal or daytime enuresis occur. Pure diurnal enuresis without any nocturnal enuresis is rare. Enuresis is usually involuntary but can rarely be intentional. Enuresis can also be divided into primary and secondary, where primary enuresis is where bladder control has never been achieved, and in secondary enuresis, bladder control is lost after having been gained and maintained for at least 6 months. Secondary enuresis may suggest an underlying emotional disorder. About 10% of children have enuresis at age 5, 5% at age 10, and about 1% at age 15. Nocturnal enuresis is more common in boys, but diurnal enuresis is more common in girls. In older children, secondary enuresis is more common than primary enuresis. Enuresis causes parental unhappiness and also limits the activities of the child. Genetic factors are important in the etiology of enuresis. Having a family member, especially a male family member like father, with a history of enuresis significantly increases the risk of both primary and secondary enuresis. Psychological stressors such as parental divorce, death, conflict, or illness in the child leading to repeated hospital admissions, sexual abuse, or birth of a sibling. Social factors such as low socioeconomic status or being brought up in care may contribute, possibly because of improper or inadequate toilet training. Other biological factors may include delayed maturation of the nervous system, reduced secretion or reduced effectiveness of antidiuretic hormone, diabetes, urinary tract infection. Consider this especially in girls and in diurnal enuresis. Other renal or urological anomalies, epilepsy or other neurological problems, side effect of medication such as diuretics or antipsychotics, nocturnal enuresis is usually seen by pediatricians or primary care physicians. A thorough assessment is important. Physical examination would be useful. It is important to rule out any potential contributory physical cause. If needed, a referral to a psychiatrist for further assessment can be considered. Reassure the parents and child that it is a common condition. Advise the parents that the child is not to blame and that punishment will not be effective. Parents are encouraged to praise and reward the child for not bedwetting rather than criticizing and punishing if the child is enuretic. Almost all cases resolve with time. Restrict fluids before bedtime and encourage the child to pass urine in the toilet just before going to bed. Behavioral strategies such as star chart can help. Enuresis alarms have been used with good success rates. Medication options include intranasal desmopressin, which is a synthetic analog of ADH, or tricyclic antidepressants such as low-dose imipramine. We now move on to school refusal. In school refusal, there is refusal to go to school because of fear. When attempts are made to convince the child to go to school, he or she starts pleading, crying, etc., that they be allowed to stay at home. If the child manages to leave for school, he or she returns home before reaching school or shortly after reaching school. The child typically reports somatic symptoms such as abdominal pain, headache, etc., and tries to give these as excuses for staying at home. These symptoms only occur at the time when the child is leaving for school. This condition is also called school phobia. School refusal is not truancy. In truancy, the child leaves for school but goes somewhere else without the knowledge of parents and carers. The onset is usually insidious but can also be abrupt. Factors that might trigger school refusal include change of school, starting a new term after a holiday, resuming school after a break due to illness. School refusal is usually conceptualized as a separation anxiety disorder, where the child fears that something bad would happen to oneself or to one's carer, usually the mother. In some, school refusal may be a reflection of an underlying social anxiety disorder. The child also usually has difficulty sleeping alone and refuses to go for activities that involve staying away from home. But sometimes there might be an external valid reason for not going. For example, being bullied. Overall prevalence is about 1% among school-going children, has a similar prevalence in boys and girls. The incidence increases when the child starts primary school, middle school, and high school. The older the child, the less likely it is for the parents or carers to be able to convince the child to go to school. Behavior therapy is the treatment of choice. The shorter the duration of school refusal, the faster the likelihood of recovery. Involve parents and teachers. Parents to enforce firm boundaries so that the child realizes that not going to school is no longer an option. Teachers can offer additional coaching for helping the child make up for lost school time and also ensure that any contributory cause at school, such as bullying, is addressed. If school refusal has become chronic, then systematic desensitization involving gradually increasing the duration spent at school may be necessary. If anxiety symptoms are very high or if there is an underlying depression, antidepressants can be considered. Changing school is not advisable unless there is clear evidence that school factors such as bullying that the teachers are unable or unwilling to tackle are to blame. We now move on to elective mutism. This is also called selective mutism. The child is mute in certain situations but is able to speak normally in other situations. Typically, the child is able to speak normally at home with close relatives, and the child is mute at school in the presence of teachers and peers. The converse, whereby the child is mute at home and has normal speech at school, can also occur but is rarer. The child has normal expressive and receptive language abilities. Elective mutism usually has its onset between the ages of 3 and 5. It usually becomes apparent when the child starts school. About 1% of children starting school display elective mutism. It is more common in children who speak a different language at home. It is equally common in boys and girls. Sexual abuse is a postulated risk factor for developing elective mutism. Elective mutism is a strong risk factor for developing social anxiety disorder in future. It usually resolves spontaneously, but the longer it persists, the less likely is it to remit spontaneously. If it persists, CBT in the form of systematic desensitization can be helpful by gradually encouraging the child to speak in front of strangers. If there is an underlying problem such as stammering that is masquerading as elective mutism, that would need to be addressed. SSRIs may be an option in treatment-resistant adolescents, especially if social phobia symptoms are prominent. We will now look at sleep disorders. Normal sleep is divided into two categories: non-rapid eye movement or NREM sleep and REM sleep. NREM sleep is further divided into stages 1 to 4, and NREM and REM sleep alternate in a cycle that lasts about 90 minutes. There are about 4 to 6 cycles per night. REM sleep occupies about 25% of sleep duration. Recalled dreams occur during REM sleep. As sleep progresses, the duration of REM sleep gradually increases with a corresponding decrease in non-REM sleep. REM sleep is also called stage 5 or paradoxical or desynchronized sleep. The main sleep disorders in children are nightmares occurring during REM sleep, night terrors or sleep terrors, and sleepwalking or somnambulism, which occur during non-REM sleep. In nightmares, the child wakes up after experiencing intensely frightening dreams. The dreams involve themes of threat to survival or to self-esteem. The dreams are vividly recalled and hence cause marked distress. They occur during the second half of nocturnal sleep, usually start between the ages of 3 and 6 and increase in prevalence after that. Nightmares are more common in females. In night terrors or sleep terrors, the child gets up from sleep with a panicky scream and intense anxiety. There is bodily motility and autonomic hyperactivity. Night terrors occur during the first third of nocturnal sleep. The child is unresponsive to efforts of others to calm them down. There is amnesia for the episode after waking up, and there may be a short period of confusion. In sleepwalking or somnambulism, the child rises from bed and walks about for between several minutes and half an hour. These episodes occur during the first third of nocturnal sleep. The child has a blank, staring face during the episode, unresponsive to communication by others, and can be woken up only with considerable effort. And as with night terrors, there is amnesia for the episode after waking up, and there may be a short period of confusion after that. Specific treatment is seldom required, and most children grow out of these sleep disorders naturally. Educate and reassure the child and parents. In some cases of nightmares, there can be a side effect of suddenly stopping psychotropic medication due to so-called REM rebound, or there may be a symptom of PTSD, so identify and address those causes. For night terrors and sleepwalkings, scheduled awakenings where the child is woken up gently about 30 minutes prior to the expected time of an episode, and then allowing the child to go back to sleep again. For some patients, benzodiazepines such as nitrazepam can be beneficial. We will now look at stammering. This is also called stuttering. It is a disorder of fluency of speech. The DSM term is childhood onset fluency disorder. It is characterized by repetition or prolongation of syllables or sounds or words, frequent pauses or hesitations, circumlocutions. While speaking, the child may exhibit extra physical effort, eye blinking, fist clenching, etc. Some children deal with the problem by simply not speaking at all or avoiding asking questions in class or using the telephone at home. Children who stammer may find that they are quite fluent if they sing, whisper, or speak as part of a group, or when talking to pets or inanimate dolls. Stammering usually begins between the ages of 3 and 5. 90% of cases are evident before 8 years. 1 in 20 children will have a stammer at some time, but most recover with or without help. It is 4 times more common in boys. Only 1% of adults stammer. Contributory factors include family history, psychological stressors, incoordination of muscles of speech and articulation, hearing impairment, and very rarely head injury, brain tumor or stroke. Among children, especially girls, the likelihood of spontaneous recovery is high. If stammering persists for more than 5 years, spontaneous recovery is unlikely. The simplest treatment advice that helps many sufferers is try to speak more slowly. Speech and language therapy options include fluency shaping therapy, stuttering modification therapy, electronic fluency devices. Counseling or other psychological treatments can be considered if there are significant emotional issues. Social skills, assertiveness, and communication skills training can be useful. For severe cases, psychotropics can be tried. The following disorders that are usually diagnosed in adults can also present in children: schizophrenia, mood disorders like depression and bipolar disorder, anxiety disorders, and eating disorders. Similarly, children can also present with conversion disorders. So those who are interested, please watch my lectures on each of the above 5 topics for more information. Before we conclude, we'll go through a set of 5 MCQs. Question 1. Which of the following childhood sleep disorders does not occur in non-REM sleep? If you want, you can pause and select your choice. And the correct answer is A. Nightmares. Nightmares occur in REM sleep. The other 3 occur in non-REM sleep. Bruxism refers to teeth grinding during sleep. Question 2. Increased prevalence in girls than in boys is a feature of which of the following disorders? If you want, you can pause, go through the options and select your choice. And the correct answer is D. Diurnal enuresis. This is more prevalent in girls. School refusal is equally prevalent in boys and girls, while B and C are more common in boys. Question 3. Which of the following is not correct regarding the pharmacotherapy of childhood psychiatric disorders? If you want, you can pause, go through the options and select your choice. And the correct answer is C. A, B and D are correct. C is incorrect because clonidine is indicated in the treatment of tic disorders. Question 4. Which of the following is true regarding conduct disorders? You can pause if you wish and select your answer. And the correct answer is D. Young children with ODD are at higher risk of developing conduct disorder as they get a bit older. A is false because reactive and disinhibited are 2 types of attachment disorder. Truancy rather than school refusal is commonly seen in conduct disorder. And conduct disorder is particularly associated with future antisocial personality disorder. The final question, which of the following is correct? You can pause if you wish and select your option, and the correct answer is B. Elective mutism is associated with the future risk of developing social anxiety disorder. A is false because school refusal is generally considered a manifestation of a separation anxiety disorder. C is false because socialized and unsocialized are types of conduct disorder. And D is false because stammering is a disorder of speech fluency. And that brings us to the end of this presentation. Hope you found the information useful. Thank you for watching.